Vascular lesions during pregnancy. Key concepts. Cerebrovascular disorders during pregnancy and the puerperium are infrequent, but can be devastating to the mother and fetus. Therefore, the management of these conditions required an experienced multidisciplinary team that considers both the mother, the fetus, and the newborn, and can coordinate the care and includes the gestational age, fetal viability, and mode of delivery in the decision-making process. The most common neurovascular issue in pregnant women is aneurysmal subarachnoid hemorrhage. Less common conditions include IVMs, intracerebral hemorrhages, thrombosis, and others. Stroke. The incidence of cerebrovascular ischemia in pregnant women vary widely. The risk for stroke is greatest 2 days before delivery and 1 day after, and the evaluation includes a head CT, an MRI avoiding gadolinium, and ultrasounds of the carotid. Arterial embolisms or thrombosis accounts for 60 to 80% of all cases of ischemic stroke during pregnancy, and acute ischemic stroke is treated with a VTPA and mechanical thrombectomies following standard guidelines. If anticoagulation is needed for the short or the long term, heparins should be used, as they do not cross the placenta and there is no evidence of teratogenicity. If antiplatelets are needed, low-dose aspirin is the medication of choice. Intracranial venous thrombosis has an incidence of 1 every 2,500 to 1 every 10,000 delivery, and accounts for about 20 to 40% of all ischemic stroke during pregnancy. Most cases occur in the second and third week postpartum, not during pregnancy. About 70% of cases involve multiple venous sinuses or cerebral veins, and the cortical veins are more commonly involved than the deep cerebral or cerebellar veins. Diagnosis includes CT and MR, and the management is assure adequate hydration, treat elevated intracranial pressure, hydrocephalus, and seizures. Treatment option for the thrombosis includes high dose of heparin and endovascular therapies as needed. Mortality rate can be as high as 33%. However, survivals usually have a good neurological outcome. Postpartum cerebral angiopathy is a group of cerebrovascular conditions associated with ergot derivatives, eclampsia, and reversible cerebral vasoconstriction syndrome. Angiography can be performed in these patients, and they have in common irregular narrowing of the affected blood vessels. The management involves reversal of any precipitating factors, triple H therapy, and calcium channel blockers. Cerebral aneurysms account for half of the cases of intracranial hemorrhage in pregnant patients. The incidence is 5 times higher than in non-pregnant patients. However, it is controversial if pregnancy is risk factors for aneurysmal rupture. Unruptured, asymptomatic, stable aneurysms typically do not require intervention during pregnancy. However, unruptured aneurysms should be treated if they are symptomatic or enlarging. The risk of recurrent bleeding during pregnancy in cases of ruptured untreated aneurysms is 33 to 50%, with high mortality rates, and therefore microsurgical or endovascular treatment is warranted. If anti-seizures medications are needed, the lowest possible dose of carbamazepine appears to have the best risk-benefit profile. If the cerebral aneurysms have been definitively treated, most experts and guidelines would recommend that the mother may undergo labor and the vaginal delivery. Indications for cesarean section includes severe clinical state of the mother, if the aneurysm is diagnosed at the time of labor, and if the interval between labor and treatment of the aneurysm is less than 8 days. Arteriovenous malformation cause 21 to 48% of hemorrhages during pregnancy and puerperium. Some authors have found an increased risk of rupture. However, others have not found such an increased risk, and currently pregnancy is not considered a risk factor for arteriovenous malformation rupture. Because of the hypertensive nature of vaginal childbirth, most authors recommend cesarean section at the time of delivery. And the woman who undergo radiosurgery treatment for AVM should avoid pregnancy until obliteration is documented. Other uncommon cerebrovascular conditions that are specific for pregnancy are metastatic choriocarcinomas, which are highly malignant gestational trophoblastic neoplasias that have a very high rate of spontaneous hemorrhage, which can occur in the parenchyma and the subdural space and in the subarachnoid space. In addition, the metastases can invade the arterial walls, leading to weakened arteries and fusiform aneurysms called oncotic aneurysms, which have a high tendency to rupture or thrombose the artery and warrant treatment. Finally, moyamoya disease. Cesarean section is generally recommended as the active labor provokes hyperventilation-induced cerebral ischemia and hypertension, and performing cerebral revascularization prior to pregnancy versus post-pregnancy is associated with lower odds of perinatal stroke or TIAs.